Professor Uma Maheshwari, madam. She's a professor from the Department of Pulmonary Medicine at St. John's Medical College in Bangalore. She'll be talking on IPF, diagnostic approach and management. Over to you, ma'am.
Thank you. Can you hear me? Yeah, is everyone awake? You had coffee, you should be awake. I think Dr. Aparna has told a lot about radiology. It's going to be a bit repetitive because the time when I trained, when I was listening to Dr. Aparna's talk, I was reading the paper we published nearly 20 years ago from PGI about IPF. That was my DM thesis. And at that time, we had these huge CT scans which we used to look and call everything as Hammond-Rich or CFA or IPF. And what was not sarcoid was IPF. And somewhere along the way, we would identify a CTD or two. And we used to treat them with steroids and colchicine and whatnot. And a lot of things have evolved since then. Okay, from the 2002 guidelines to guidelines coming every few years, a lot of things have evolved, and we have evolved a lot radiologically in moving from biopsies to making radiological diagnosis. So some of it will be repetitive, and I think repetition reinforces learning. And since Dr. Aparna has made such a good point, I expect this session to be even more interactive. So can we expect interaction? Yeah. No yes for even that? Okay. So over the next maybe 20 minutes or 22 minutes, I'm going to talk about how to approach a case of idiopathic pulmonary fibrosis. And let me tell you, once you have started looking into causes of IPF, the causes of ILD, the number of IPFs we are seeing are dwindling because we are picking up something or the other. We are picking up a CTD workup positive, an exposure positive. We are picking up a myositis panel positive. Something is coming positive. So our pickup rate of the so-called IPFs is really decreasing even in our center. I had claimed to have seen 76 cases out of 144 20 years ago. I can no longer say that. When Kavita and I started looking for radiology, we had a lot of difficulty finding a classic IPF case. So it is coming down now, but we need to know that there are IPF cases and that it is largely a diagnosis of exclusion, and you have to make a meticulous search, identify the typical pattern, and then diagnose. So with this, I have spoken quite a lot. I expect it to be quite interactive from here onwards. So let's start with a clinical case. Coincidentally, my case is also a 65-year-old man. He was a businessman. We saw him in around 2016-17, just before the guidelines came out. He came with a 2-year history of progressive dyspnea and dry cough, which was MMRC grade 3 at presentation. He had no occupational or domestic exposures, did not have any muscle weakness, skin rash, ocular symptoms, or any symptoms of CTD, no joint pains. He had no comorbid illnesses. He was a reformed smoker of 100 pack years. So understandably, in the peripheral center where he was seen, he had been treated with inhaled medication. Somebody found some crackles. They thought it's COPD. He had been treated with inhaled medications. When things got worse, he had got some bursts of corticosteroids and he came to us. So on examination, he had grade 2 clubbing, 90% saturation on room air, and bibasal end inspiratory velcro crackles on respiratory examination. He came to us about 2 years after onset of illness. So this was a chest X-ray at onset of symptoms. For some reason, I'm not able to, okay, the laser pointer is, okay. So this was the chest X-ray at onset, which looks quite unremarkable to a general physician. But if you put a retroscope, one of my profs used to call it a retroscope. So if you put a retroscope after seeing this, there are some interstitial shadows on the chest X-ray. Here you can see full-fledged reticular-nodular shadows. So will we let it rest at this? No. We will probably do further imaging to see what we are dealing with, especially if he comes into a pulmonologist practice. We did a functional assessment to start with. So you can see that on the lung function test, the curve does not look like COPD at all. Somehow I'm not able to get the pointer there. But anyway, it is looking restrictive. The curve is looking restrictive. And there was an impairment of DLCO, so no question of COPD there. But again, he had a smoking history, didn't have a wheeze. It is fitting into ILD. The provisional diagnosis was interstitial lung disease. We wanted to delve deeper. We did a further workup on this patient. The RA factor was negative, ANA was negative. We did an immunoline that was also negative, myositis panel also negative. So I'm not going into details. Further speakers where things came positive will discuss more about these things. So we did a CT scan. So you can see here it'll run pretty fast. So what you can see is this patient has come far into the illness. So from the apex to base you can see abnormalities. You can see there is a lot of honeycombing. It's not respecting any borders. Lot of honeycombing. And as you go down, you will see inter and interlobular septal thickening. It is also there anteriorly, it is there posteriorly as well. And as we go lower down in the CT scan, you will see there is traction bronchiectasis, bronchiolectasis, and there is honeycombing. And it is involving both lungs. So we did make a diagnosis of IPF in this patient. He came 2 years into the illness to us. And when we dissected a bit further, to look at the so-called gradients Dr. Aparna was talking about. Yes, there is an epicobasal gradient in this patient. The lower lobes are involved much more than the upper lobes. There is honeycombing, there is inter and interlobular septal thickening, and there was honeycombing. So this patient, a diagnosis of ILD was made, and the patient was it idiopathic pulmonary fibrosis? Yes, it fit into all the picture. We'll go into details to see why we made it IPF. And then the patient was subsequently managed, which we'll discuss along the way when I talk about IPF. So what is IPF? So I'll basically be discussing the guidelines, the 2018 guidelines which came and the 2022 guidelines which were an update which included both IPF and PPF. So mainly based on the guidelines, what do we do when we suspect IPF? What needs to be done? Why is radiology important? Why is MDD important? This will be a recurring theme throughout the day, and it's important to reinforce this. So what is IPF? It is a specific form of chronic fibrosing interstitial pneumonia of unknown cause, which means we should have ruled out known causes. It occurs in older adults, but remember, time and again studies from our country have proven that it is not 60 plus. We do see it in younger people in our country. It is limited to the lungs, and it is associated with a radiological and or histological pattern of usual interstitial pneumonia. So for younger trainees here, the keywords you need to remember is it's progressive fibrosing, it doesn't have a known cause, and it is seen in older people and UIP. So these are the buzzwords you have to remember when you are thinking of IPF. So what are the clinical clues? The demographic profile is usually older subjects, men more than women. If you see it in younger people, please start digging for a family history. Start looking for CTD. Start looking for interstitial pneumonia with autoimmune features. This will be discussed by subsequent speakers. Symptoms are usually cough with unexplained chronic dyspnea. Of course, it goes without saying that you have to examine the patient. Somebody with cough and unexplained dyspnea, all of them are not ILD. You have to look for suggestive findings like clubbing, which may or may not be present, but is usually present, bibasilar velcro crackles, and risk factors like smoking and gastroesophageal reflux. Again, need not be present, but these are known risk factors. So if you have this clinical profile, only then what I keep telling my trainees also is that clinical diagnosis is multi-layered. It is not I look at an X-ray and I make IPF. I look at the patient, I look at the demographic profile, I look at the clinical presentation, examination findings, lab findings, radiology, and then make a diagnosis. I don't start with the X-ray and say this is IPF. So on this clinical layer, when I find suggestive radiology and lab findings, then I consider IPF. So what diagnostic workup is recommended in people with IPF according to guidelines and what evidence has emerged? A functional assessment obviously we have to do, because we'll be putting these people on treatment and we need to know what treatment is doing or not doing. Is the disease progressing? So functional assessment consisting of a spirometry, DLCO, 6-minute walk distance. This is similar for all ILDs. Immunological and serological tests, because I said when all other causes have been ruled out. Radiology and histology is for characterization of ILD, but with good radiological resources, we are going away from histology unless we are considering alternative diagnosis, unless we are considering non-CTD ILD, unless we are considering non-HP kind of ILD. When we don't have exposures, when we don't have a CTD to explain, when we are thinking of alternative diagnosis, that's when we are looking at histopathology. So we need these things for characterization, to inform therapeutic decisions, and for prognostication. So you might ask, radiology is looking suggestive, why can't I put patient on treatment? We need to prognosticate. I need to see if it's progressing, what is the extent of abnormality and what is happening. So again, it is multi-layered. Functional assessment, radiology and histopathology will tell me where the patient is heading to with my treatment. That's why at every point, it has to be all things put together and then look at the patient. So is the diagnosis of IPF an open and shut case most of the time? What is the step-by-step approach to demystify? Here is where some things will get repetitive, so I'll go fast and probably you have to help me in uncovering my slides. So in clinical evaluation, any newly detected ILD of apparently unknown cause who are clinical IPF suspects, I have to take a detailed history, including medication use. We have picked up many amiodarone ILDs, many other bleomycin ILDs, people who are on chemotherapy who develop ILDs, so medication use is very important. Occupational, home and other potential exposures. It may not be occupation and home. Somebody may be visiting a place often and they may get exposed there. So that also is important. Serological testing, recommended ones are ANA, RA factor, anti-CCP, immunoline and myositis panel. May not be available in on centers, so if you're working in a peripheral center, pick up an ILD, don't jump and start treatment. Maybe time to refer to a center where all this is done. So you have to do all this before calling them IPF. And what the pulmonologists need to know to decode the ILD, imaging basics was covered. We need to know the salient abnormalities, the patterns characterizing, even if you don't have access to a video or a system where you can see serial abnormalities on the CT. On reading a report, you need to know whether it looks like UIP. We need to know about geographic distribution of abnormalities, and we also have to know what is not characteristic of UIP. In my talk, I'm covering only IPF UIP, so we need to know what does not look like UIP. The imaging modalities, most of the residents here will be filling forms. So don't write CT thorax. We have to know what we need to fill up for the radiologist to do. In high volume centers, a technologist will be doing it. You fill CT thorax, a normal CT thorax will be done. We need to know what scanning protocols that is usually followed in all centers. We have to know about supine, prone, inspiratory, expiratory imaging. Especially in newly established centers, you don't write about inspiratory, expiratory, you'll miss air trapping. So you have to know what to fill up. And you don't have to write contrast CCT or NCCT in all patients. A high resolution CT is enough to pick up parenchymal abnormalities. We will come to when we need a contrast enhanced or a CTPA. So technical considerations were dealt with, but what you need to know in the technical considerations is that you need to look at thin sections of the lung, you need to do volumetric imaging, and to pick up abnormalities like ground glassing, nodules, traction bronchiectasis and honeycombing, you need to go all around the lung and you need to look at thin sections of the lung. So that is what is summarized in this slide. This was already covered by Dr. Aparna. So typical features, honeycombing. So can someone recap about honeycombing? I think the person in the first row asked a lot of questions. How much honeycombing is enough? Single stack is enough? Multiple stacks are required? Single stack is enough. Okay. So what are the DDs for honeycombing? I think Dr. Aparna put it up. Yeah? Cysts and what else? Paraseptal emphysema, good. So we have to differentiate between the two, and how do you learn? You don't learn by memorizing, you learn by looking. So even if you have a report, if you have access to the CTs, please keep looking at CT scans, you learn. We also have built-in artificial intelligence. The way we learn is to keep on looking at films. So clustered thick-walled cystic spaces, I mean, these things you can learn anywhere, but by looking at films is how you will learn what honeycombing looks like. So this is how honeycombing will look like. I'll see if I can, okay. So this is what honeycombing will look like on the CT. Honeycomb looks like honeycomb. Anybody who has seen a beehive will know what honeycomb looks like. Even a single stack of cysts is enough. And if it's predominantly in the lower lobes, it is suggestive of UIP. So what is traction bronchiectasis and broncholectasis? So how is it caused? It's already there, you don't have to read up. But if there is only traction bronchiectasis and broncholectasis, which category of UIP does it fall into? Probable. Okay, it falls into probable if only that is there. But if it is there with honeycombing, then it is definitive. So something which you need to know about this is the surrounding lung parenchyma undergoes fibrosis, so it pulls apart the bronchioles. That's why you get traction bronchiectasis and broncholectasis. They are important prognostic markers, which means beyond the interlobular septal thickening, the fibrotic process is extending into the lung parenchyma. And it will correlate with what functional impairment? So let's move from structure to function. It will correlate with poorer lung function, isn't it? It may correlate with more cough. It may correlate with more symptoms. So presence of traction honeycombing, traction bronchiectasis, broncholectasis, which is increasing, may make the patient more symptomatic. It will help you communicate better with the patient if you know what you are seeing on CT and in the spirometry. And they are usually seen in the periphery of the lungs. Reticular pattern and GGO. So is GGO a feature of UIP? Mild GGO can be there. When? Yeah? Progression of disease. Progression when? So usually you don't see only GGO in UIP. Usually it is superimposed on an underlying reticular pattern. Okay? So I am not talking about the text there because it has been covered. Usually it is superimposed on an underlying reticular pattern. We used to talk of the so-called Hammond-Rich syndrome earlier, which was AIP. It used to be lumped under IPF. Dr. Christopher spoke about it. Now it's a distinct entity. So you usually see it superimposed on a UIP pattern. And when you see GGOs in a UIP, it's an acute flare. Okay? So this is something you need to know. When you see a CT, always talk of classical abnormalities and look for a epicobasal gradient, look for an anteroposterior gradient. That's why we were talking about supine prone imaging also. If there are subtle abnormalities, supine prone imaging becomes important. So look for, so you can see here the epicobasal gradient, which is coming out very well. Not much in the epicis, seen better in the basis. On a coronal reconstruction, you can see very clearly how there aren't too many abnormalities in the epicis, but quite a lot in the basis. So the radiological patterns were again covered. So typical pattern, probable pattern, indeterminate pattern, and alternative diagnosis. So I'll quickly run through these slides. The typical pattern is honeycombing with traction bronchiectasis and broncholectasis. The probable pattern is no honeycombing with traction bronchiectasis, broncholectasis, and fibrosis. Indeterminate is only fibrosis, so one by one things start disappearing. You get only this much, and alternative diagnosis is everything else. So again, this I cannot teach you in a class, it comes with practice. So coming back to our patient, I put this earlier. We saw that this patient had honeycombing. He had traction and bronchiectasis and broncholectasis. He had honeycombing. So which category does he fall in? We ruled out everything else. So which category of UIP is he? Definitive, probable, indeterminate, alternative. What I noticed was as we progress in our talks, you become quiet. And my timer is running out. I may have to stop in between. Is it definitive, probable, indeterminate? This is our patient. Yeah, how many think definitive? Okay, you won't talk, you'll raise your hands. How many think it's definitive? Some people in the far back are more, okay. Indeterminate? Nobody. Probable? No, okay, some of them. Alternative diagnosis? Okay, it is definitive UIP. So we did a kind of MDD here itself. So it is definitive, this patient was definitive UIP. You can also see the epicobasal gradient, and I have also put anterior and posterior reconstructions. You can see it's much more in the posterior when compared to the anterior. So this patient was definitive UIP. We put him on antifibrotic agents, pulmonary rehabilitation, and he is on periodic follow-up. So back to the diagnosis and management. Should we do a BAL? Now we have done all this. It's our pulmonologist's trigger finger that we want to put a bronchoscope in everybody. The bronchoscope is a stethoscope. So can I just go in? His FEV1 was more than a liter. Can I just go in and do a BAL and see what is there? We should do a BAL only if I'm suspecting a superadded infection or if I have an alternative diagnosis. So no question of BAL in this patient. Should I do a lung sampling? I want to see what was shown in the first slide, that beautiful H&E picture with islands of fibrosis and Mason's trichrome showing fibrosis. Do I want to see it? It is indicated only when HRCT shows indeterminate UIP or if an alternative diagnosis is there after an MDD. We'll come in a moment when I need an MDD. Should I do surgical biopsy? I have a cryoprobe. Can I do a transbronchial cryobiopsy? Definitive UIP is more feasible or is more visualized with a surgical lung biopsy because, as I showed you on the CT, this is a peripheral disease. If I go and sample from the center of the lung with either a transbronchial lung biopsy or with a cryobiopsy, my probability of getting typical features of UIP are very less. I may get some islands of fibrosis. If I do a surgical or a VATS biopsy, characteristic features can be picked up because all the features are peripherally located. Can I do transbronchial cryobiopsy? The 2018 guidelines said no, but they have become more benevolent now. The guidelines now say that you can do it in experienced medical centers with standardized protocols where you know the risk benefits. You have a rigid bronchoscope, you have an endobronchial blocker, you have adequate expertise, then you can do a cryobiopsy. So cryobiopsy is not for all. You have to be experienced, and MDD should say a biopsy is required, and you should have an indeterminate pattern. So there are many layers or filters before you consider cryobiopsy. So those of you who have a cryobiopsy probe, don't jump and start doing cryobiopsy in everybody where IPF is suspected. Contraindications for lung sampling are standard: low FVC, pulmonary arterial hypertension, hypoxia, and somebody with a bleeding risk. So histopathological classification is as fanciful. I won't go into details. Again, it falls into the same 4 categories. And then what are the diagnostic criteria? So you have to exclude other causes. If you have a HRCT pattern of UIP, definitive UIP, no need of a biopsy. If you do not, then you can go through this grid. I'm not going through the grid here. It will take half an hour if I do that. But if you have specific patterns subject to lung tissue sampling, this is all there in the guidelines, then you can do this. But this again will come after an MDD. So is this clinico-radiological jigsaw solvable only by the pulmonologist? Can I sit in my clinic and do all this? Yes, I can, but we were just discussing that most of our patients stump us. We get stuck at some point or the other. Radiology is stumping us. It's not looking as clear-cut as I showed you. So what we do is, we do resort to multidisciplinary teams and multidisciplinary discussion. So what is the role of MDDs? Do we have to do MDD for every patient? Typically, it's composed of a pulmonologist, radiologist, and pathologist, but it is expanding now. It's a chronic disease. So, and it is a multidisciplinary disease. Many times a rheumatologist is involved. Many times or more often than not, a palliative care physician is involved. Because it's a chronic disease, they have lots of issues. I can't start prescribing dyspnea management or cough management or pain management in these patients. So it is evolving, but for diagnosis, this trio is enough. It enables me to combine existing evidence with clinical reasoning. So MDDs are the buzzword for ILD. But the caveat is team members should have adequate expertise. Any three cannot sit in a room and start to diagnose. So that's why all of you are here. You have to upskill before you become part of an MDD, whether it's a radiology, pathology, and that's the whole purpose of the INPF meeting. We are trying to upskill people to achieve expertise to become part of an MDD to diagnose ILDs. So when is MDD necessary? When there's an indeterminate ILD. Post-biopsy to integrate clinical imaging and histological features. For evaluation when the longitudinal course of the disease is discordant. It will not go smoothly. It's like Indian roads. A lot of things will come in between. Patient may develop a malignancy. They may develop another autoimmune disease. Or they may react to a drug and something else might come up. So when the longitudinal course of the disease is discordant, then an MDD may have to reconvene. And when diagnostic tissue is not available, to consider a working diagnosis of IPF, an MDD may be required. So this is the diagnostic algorithm. When somebody is suspected to have IPF, if you find a potential cause or associated condition, you can confirm the diagnosis and it goes into the alternative diagnostic algorithm which will be dealt with. If the CT pattern is UIP or probable UIP, it is IPF. If it is indeterminate, convene an MDD, decide about a biopsy, and then again reconvene an MDD, and then decide whether it's IPF or alternative. Looks very simple, but forming the MDD and getting there is the difficult part. Even in tertiary care centers, it's very difficult. So what's the natural history? Very variable. That makes it even more difficult. Some people progress slowly. Some people have exacerbations, some of them have catastrophic progression, and mortality is high. This kind of progression is seen. The West, many of them progress very rapidly. In our country, it's very, very variable. It follows any of the three paths. What are the management principles? Antifibrotic agents, supportive care, palliative care. Many patients do not come to us into the lung transplant queue, but if we start picking up earlier and earlier, maybe yes. And palliative care consists of chronic cough and dyspnea management. Advanced directives have to be discussed because this is a progressive disease. Despite all that I do, I slow the progression of disease. I do not stop the disease. So I have to talk about advanced directives. Caregiver counseling is very important. Consideration for hospice care and in end-stage IPF is also very important. And on follow-up, how frequently, 3 to 6 monthly and as needed. I have to look at quality of life, assess functionally, look for desaturation, prescribe oxygen, do pulmonary rehabilitation, and other supportive measures. So the summary of management strategies is treat the patient, follow up periodically, and then evaluate if you're picking up early enough. And lastly, acute exacerbation of IPF. Again, this was dealt with by Dr. Aparna. Basically, anything lasting less than a month, or typically less than a month, worsening of symptoms qualifies for an acute exacerbation. A CT showing new GGO or on a background of UIP, I already discussed this. And you have to rule out here also other causes, like infection, pneumothorax, thromboembolism. Typical triggers are infections. Sometimes undue stretch of the lung has been implicated, but I can't prove that clinically. Acid reflux seems to be an important trigger. Again, we can't go about proving, we only have to treat. So this is how an acute IPF exacerbation will look. You will have GGO on a background, on a background of ILD. How do you treat? Again, identify an extraparenchymal cause. Then you don't call it AE IPF if you find a pneumonia. If you do not, then You find if it is not fully explained, it's not an acute exacerbation. You don't find a cause. It is either triggered with something or it's an idiopathic exacerbation. You don't find any cause at all. Your procals are normal and there is extensive GGO. There is no left heart failure. Then you treat with systemic corticosteroids. Evidence is tenuous, but we don't have any other option. Supportive care is also given, including mechanical ventilation. And in summary, IPF is a distinct ILD that requires diligent evaluation and a directed workup. You have to look at suggestive clinical picture with a definitive or probable UIP pattern. Lung biopsy is not required in all cases except if it is indeterminate or if you are considering an alternative diagnosis. MDD is very important in these cases. Disease trajectory is variable and is managed with antifibrotics and supportive care. Thank you.
Thank you, ma'am. That was a very well presented topic with exceptional clarity on the topic of idiopathic pulmonary fibrosis. We have time for a couple of questions. Are there any questions from the floor?
If there are no questions, I have a couple of MCQs.
If I
so you
can
better
ask
ask questions.
If I can ask a few questions, ma'am, for the benefit of the audience. You presented a patient of 65 years of age, but as you move the age group, say, for example, to an 80-year-old person, do we really need to do autoimmune serology, or could we just take it for granted that when you see a UIP pattern, which is definite, it is IPF?
We do workup.
Even in the extremes of age. Rheumatoid, yes, but ANA and CPK, or my...
CPK in all cases, but we do RANA to start with, we do in all cases.
Yes, we have a question.
Biopsies. But sometimes if a young aged patient, suppose young aged means 55 or 50, comes with probable UIP and we are not sure enough. So should we go ahead with biopsies in that?
What should you do in a young patient? That means you haven't seen the algorithm. A very young patient, what do we do? What additional questions should you ask if the CTD workup is complete?
So all those have been ruled out, suppose.
No, we haven't. There's one more thing I said you should do in a young patient.
Familial workup. Yeah. We don't do usually for genetic testing.
Before going to lung biopsy, you have to ask for a family history also. Exposure history, family history is also very important.
I think what madam is saying is the lung biopsy, what you will get? You will get only the pattern. So if it is a probable UIP pattern on CT scan, then studies have already shown that almost 80 to 90% of those, if you perform histopathology, the pattern will be same. So the lung biopsy is not giving anything additional. You are saying probable UIP on HRCT, the same will be there on histopath also. So you will not get any additional, this one. Yes. So it will be ultimately IPF only.
Whatever happens. The problem arises if you get discordant, then you will be stuck. You will not know what to do. The question is between giving immunomodulation and antifibrotics. For immunomodulation, you are doing a CTD workup. And for antifibrotics, you have already had it on CT. The only issue left is do remote family diet.
And I just want to add that the clinical picture is so important because if it's a young female with some tinge of connective tissue, then if you look at the CT description, probable UIP and fibrotic NSIP have no difference. So it's with what eye you look at. You're looking at from an IPF eye, it is probable UIP is IPF. But if you're looking at it from a clinical diagnosis of probable NSIP, it is a fibrotic NSIP, and then your approach would be different. So your starting point of what is your clinical possibility at the end of your history examination and initial evaluation is so crucial in interpreting what the radiology provides. Yes. Yeah. If your clinical suspicion is IPF, it becomes probable UIP. But your clinical suspicion is something else. It's same as fibrotic NSIP.
So I have time for a case vignette because, So this was a patient we saw last week. We are still working him up. 44-year-old male, works in a cement factory. He presented with a 6-month history of dry cough and progressive breathlessness. On examination, he had a normal saturation, Velcro crackles on respiratory exam. CTD workup was negative. There was no family history of any ILD. So I'll just put the CT. All CTD workup, I mean, myositis panel is awaited, but everything else was negative. So I want you to look at the CT and tell me what it is. For some reason it's not letting me play it here. No, the pointer is not going there and letting me play. Is it seen clearly enough? Maybe I can magnify it a bit. Can the people in the back, okay, there are screens there. Is it UIP, is it definitive UIP? What UIP is it? Definitive UIP. Can someone volunteer and start reading the CT? Yes, correct. Then left side. So what are we seeing? Are we seeing subpleural predominant, or is there an epicobasal gradient? Is there honeycombing?
Findings are there, honeycombing are there, anteriorly and posteriorly also some cysts are there, but predominantly it is only on the right side.
So how many of you will say it is definitive UIP? You can see only 1 or 2 hands. How many of you think it's probable UIP? I can see half a hand. Indeterminate UIP? Dr. Vijay, what do you think?
Do we have the mediastinal window also?
Mediastinal window didn't show anything. No, it's pleura is fine.
So actually this distribution is not like UIP.
It's not like UIP. I'm not able to.
Probably below as unclassified.
Yeah, it is not. Yeah, we are not very sure of what we are dealing with. So. Yeah.
Yeah, so it's very asymmetric involvement, as somebody said, and it's more on the right side. So I would definitely like to look at the prior images if there is any infection, and this whether it can be one post-infective sequelae also. So that's one thought.
Okay. This is the only imaging and only 6 months history. Nothing else was there. So we are still working up this patient. We haven't called him UIP as yet. Yes. Yeah, only one area of honeycombing is there.
So it is definitely not looking UIP.
Yeah. So the reason I put this up is what we show you are classical pictures. What hits you in the outpatient are patients like this. So that is why it is very important to have a dialogue with the radiologist, to go through the clinical history, to keep revisiting your patient each time they come to you. So next steps, we have to toy between these things. Definitely I will not do a TBCB. I will not do a lung biopsy. I will not know where to biopsy. There is one area which is fibrotic, the rest of the areas are patchy. Bowel cytology will not give me anything. There is nothing to suggest anything right now. So I have to go for an MDD and await his report of myositis panel, and wait for progression probably. Okay.
If any fistula connection to the right to main bronchus, or if any fistula, esophageal fistula, or some aspiration.
Yeah, no history like that was there. It is like ILD. Presentation was like ILD. We went and took the history again and again. So this is how actual cases will look like. What we show you are classical pictures to teach. But actually, people will come like this. That's why you need to discuss with other people to revisit the patient. Okay, thank you.
Thank you, ma'am.